Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm very pleased you could be with us for this segment. During the next 19 minutes or so, I'm going to talk about one of the areas of plastic surgery, facial plastic surgery, eyelid surgery, that is one of the most common areas that I operate on, and one of the areas that I receive the most requests for consultation regarding, the eyelids. So, before we talk about surgery of the eyelids, I'd like to talk about other treatments, for example, minimally invasive, less invasive procedures such as Botox, fillers, etc. To start, Botox, I think, can be very effective in what I call the upper third of the face, essentially the eyelids, eyebrow, and forehead. That's called the upper third of the face. The middle third around the cheeks, and the lower third, of course, is the neck and jowls. Most plastic surgeons, certainly in my office, before I will do any surgery on someone's face or associated structures, we look at a face in thirds, the upper third, middle third, and lower third. So, Botox can be very effective for the upper third of the face, for things like glabellar furrows. Glabellar furrows, the glabella is that area between the eyebrows. Some people, I think, call that the bridge of the nose, or the upper part of the nose where the nose meets the forehead. That area between the eyebrows can be affected by furrows, lines, or deep creases. One of the companies that makes this muscle relaxant calls them the 1s or the 11s or the 111s. That's because some people get 1 line, some people get 2 lines, some people get 3 lines. And that comes from contracting 2 muscles of the eyebrows, depressors of the brows, and those are called the procerus and the corrugator muscles. The corrugators run almost horizontally, slightly obliquely, but they run slightly horizontally, and the procerus runs up and down, procerus like the midline, and those muscles, when contracting, gives that look of sort of consternation or frustration, or even sometimes people interpret it as anger. When in the office, I tell people to give me a look of disapproval or consternation, and they usually know what I mean. So, that area can be very effectively treated with Botox. Essentially, Botox is a muscle relaxant. Now, there are sort of new types of Botox, Dysport and Xeomin. It's important to know that the active chemical is the same with all of those muscle relaxants, all of those neurotoxins, but the carrier is a little bit different. The way it's metabolized is a little bit different, but they're all injected with a needle. It comes in a sterile vial that we prepare. We draw it up in a sterile syringe and inject it, usually with a topical cream anesthetic and ice. It can be actually quite tolerable, and it can help relax those glabellar furrows. It's also good for the so-called laugh lines or crow's feet, smile lines at the sides of the orbits, or the lateral part, or towards the ear. Those lines that sometimes people get called crow's feet or lateral lines at the sides of the orbits. Now, it's important to distinguish that those lines of kind of squinting, those lines that develop when squinting, are different than the lines that develop when we exaggerate a smile. The reason why Botox is effective for the squinting lines is because we can get that muscle, the orbicularis oculi muscle, to relax. But what happens in a big smile or exaggerated smile, the zygomaticus muscles contract, and it's like an accordion. It pushes up the cheek tissues, and that skin folds. So those lines associated with a firm or exaggerated smile are not typically affected by Botox. And I don't like to affect someone's smile. I think a smile is beautiful even if it creates lines. So the squinting lines we can help, the so-called crow's feet toward the side, we can help, that are affected by the sort of squinting. But the laugh lines, typically we do not desire to dampen those or diminish them. Now, Botox can actually give us a little micro brow lift. Well, how do I do that with Botox? First of all, I mentioned some of the depressor muscles of the brow. The corrugators, the procerus, and the orbicularis muscle are all depressors of the brow. There's one main elevator of the brow, and that's called the frontalis muscle. If I selectively use the muscle relaxant Botox to get the depressor muscles to relax, then the elevators take over. And if I do that selectively, we can mimic that look that all the glamour models have. They have a peak of the eyebrow just at about the lateral canthus. That's the corner of the eye. So we can mimic that more in women than men. We can mimic that with Botox or bring it about by selectively getting the depressors of the brow to relax and allowing the elevators to take over. Now, I mentioned that fillers are another step in our continuum of treatment. What a filler is a volumizer. It can be a filler that comes in a box like Juvederm or Restylane, etc. There's a new one called Belotero that I like. Radiesse is a different class. It's calcium-based. Those are fillers, and that what they can do is help to revolumize a line, a glabellar furrow, done very conservatively in a very superficial way by an experienced injector. We can help treat the glabella and glabellar lines. Fillers can also help to accent the cheekbones. They can bring the chin forward a little bit, etc. I like them for those purposes. I think filling up a wrinkle is my least favorite thing to do, but fillers can be very effective in certain cases. When I talk about the lower lid, I can talk about volumizing a lower lid, especially the tear trough. The tear trough is this groove at the eyelid cheek junction. And of course, the representation or the artistic view of a beautiful face has a very smooth eyelid cheek junction. If you look at a mannequin or a cartoon representation of beauty, it's a very smooth eyelid cheek junction. If there's going to be a defined line at the eyelid cheek junction, we like it to be high and not low. And certain people just have deep tear troughs, and that's when a volumizing agent, such as a filler or even fat grafting, can be very effective. I've talked about fat grafting at other times. That's when we do, briefly, very conservative liposuction, spin the fat down or centrifuge it, decant it, and then use that for a volumizer instead of a filler. So we've talked about Botox for the glabellar lines, the so-called crow's feet. Filler can be very effective. Before I go on, I want to distinguish between a line of expression and a static line. There's a line of expression which is a dynamic line. If when you're in repose or resting your face, you do not have lines, but then when you animate or make an expression, you have a line. That's called, of course, a dynamic line or a line of expression. And some of that's good. I don't like to totally freeze people's faces. I like the natural look. I'm known for the natural look. If you still have a line or a furrow when you're in repose or at rest, that's a resting line, and that's more of when I would use a combination of Botox probably and a filler. So please keep in mind that Botox and fillers are different. They can be used in conjunction, but they certainly are different. So I've spoken a lot already about the eyebrow, and I haven't even addressed the upper lid. What's important when I look at the upper lid, when someone comes in and tells me that they feel their upper lids look tired, they feel like they have too much extra skin, that we look at the position of the brow. We have to look at the adjacent structures. Keep in mind that the roof of the upper eyelid is the eyebrow. The foundation or supporting element of the lower eyelid is the cheek. So when someone comes in and feels that they need their eyelids tended to, we need to look at the associated structures. Oftentimes I can affect the position of the brow, as I said, with Botox. If someone wants a more permanent solution than Botox, we can do a mini lift or a lateral brow lift. Sometimes I can do an internal browpexy. That's through the same incision where I do an eyelid operation. I can slip up and adjust the position of the lateral brow. I can use an endoscope, and I go in through very small incisions in the scalp, sometimes an incision in the temple, to get down to where I want to go and see. I can use a fiber optic light through a medium-sized incision On occasion, we still do the traditional coronal approach, which is a very long incision in the scalp, but far more often I do brow modification through very small incisions in the hair, at the hairline, or sometimes through the upper lid itself. So, after we evaluate the brow, I look at the upper eyelid. In general, what we're affecting with the upper eyelid is the amount of skin. If the converse is true for the lower lid, I very rarely will affect the lower lid by removing a lot of skin. But the upper lid, in general, we remove skin and very conservatively address the fat compartments. There are 3 compartments in the upper lid and 3 compartments in the lower lid. In the upper lid compartment, the nasal compartment or medial compartment and the middle compartment primarily are composed of fat. And that fat can be affected by something called pseudoherniation. The fat is held in place by a membrane. It's called a septum. In some families, with time and sun exposure, that septum can become weak and it allows the fat to start to push through. It's almost like a hernia, and in fact it's called pseudoherniation of the fat. When I address the fat in the upper eyelid, I'm very conservative because we want to avoid an overdone look, an unnatural look, or a cachectic look. The 3rd compartment in the upper lid contains the lacrimal gland that makes the tears. I'm very conservative when I address the lateral lid. I don't like to modify the lacrimal gland very much. There are certain patients where the lacrimal gland will descend or become very prominent. I don't take it out. I don't like to remove even part of it, but I will pexy it or put it back into position, put that lacrimal gland back so it still functions, but there's less of a prominence or protrusion there. Of course, when we look at the upper lid, it's also important to look at the position itself of the margin of the lid. There's a condition called ptosis, where the position of the lid is too low and it obstructs part of the visual field. Visual field obstruction, it obstructs part of the pupil. It's overlying the cornea too far, and it actually is obstructing vision. So that's a reconstructive procedure where we typically address the levator muscle that lifts the lid, and so we can correct the ptosis that way. For the lower lid, primarily we are addressing those fat pouches. I talked about 3 different fat compartments in the lower lid as well, the nasal or medial, the middle, and the lateral. We address those by modification of the volume. Sometimes I remove fat, sometimes I reposition the fat, sometimes I will actually introduce more fat into that area or fillers. Just picture if the lower lid has a full pouch, and then of course the cheek is full, and then in between there's a valley. Think of it as a mountain and a valley and a mountain. Sometimes we fill up the valley, sometimes we take the mountain down, one or the other, to make that area more smooth, because we want a smooth eyelid-cheek junction. Typically I address the fat, sometimes I reposition it instead of just removing it. Sometimes I use fat grafting, sometimes I use fillers, and very conservatively address the skin. There are other things that we can address, such as the color, fine lines. We can refinish or resurface the skin, and those can all be discussed during a consultation. Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon here in Monterey, California. If you'd like more information about this or any other topic in plastic surgery, I'm at 831-646-8661 or on the web at drmorwood.com, DRMORWOOD. Thank you so very much for viewing. This has been Your Health television program. Thanks so much for joining us.